The following show and its content are the responsibility of the show's producers and participants.
Information related in this program is not meant to substitute medical recommendations. Before starting a treatment program, you should consult your physician.
T-minus 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Ignition. Liftoff.
That's right. Welcome to the Couch Live here on the Problem Solving Network, WPSN99.com. Hello, everybody. I'm almost forgetting even how to sign in on Trinity. It's been
it's been a while, man.
It's been a while. It's like been over. It's the second week. We were gone a week, and so I almost forgot how to speak.
Oh, so, well, I'm not.
So everybody, welcome to the Couch Live.
I think you forgot how to introduce, maybe not speak.
Yeah, you're right about that. I said it wrong. Anyway. I am the Street Certified Dope Dr. Louis Delgado here with you, along with my cast of friends, of course. Trinity Phillips, the Dharma guy. Hello.
What's up?
And, of course, the Grasshopper, our intern, Robbie Barrett.
What's up, guys?
Look, his is a little long. I got to go up.
Hello.
There you go.
Man, it's still not really there, is it?
You got to make love to the microphone.
I don't know if it's my voice or the I think it's the microphone.
It must be the microphone because I have it all the way turned up. I don't know what's going on with that microphone. And that's the second one I put there. So like, there's something in that spot.
It's the cursed spot.
I think the microphone's just upset because you're not there all the time.
Because you're never on it. It misses you.
Right? It's playing.
Hey, I was here last show.
Yeah.
And the show before.
You know what? I guess he is right on that one.
He is true.
Yeah.
He's right. He's been here.
Hey, and last week you didn't even let me know there wasn't a show. So, what if I drove over here?
No, is that true?
No, I didn't. I was working, but I'm just saying.
Oh, okay.
No bueno.
Hold on. I'm going to unplug him and plug him back in because I don't like the way that sounds. Try it again.
Yep.
Nope.
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 Nope. Yep. Who's on first?
Well, let me just keep going and I'll talk a little bit louder.
Yeah. Yeah, we're going to have to do something like that because that's just weird.
Project, man.
Yeah, just talk a lot louder.
I will.
All right. Anyway. We got a pretty cool show for you today. We're talking some medical stuff today, Trinity. We're actually trying to find out what's working. Here's the real question. What is working out there? Because we don't want everybody to get so worried. This is a show that focuses on addiction and recovery and all things in between. And all too often we hear about all the chaos and the death and the overdoses and the problems and everything like that. But please, somebody tell us something's working.
Yes.
It can't not be working. Is treatment working? Are 12-step meetings working? Is the medication-assisted treatment working? I mean, and if something is working, what is working? And what are we doing about it to get more of it?
Well, I think
that's the real question.
I think that's, I think different things work for different people.
Right.
I think that's why you got to take the multi-pronged approach.
Multi-pronged?
That's right. That means more than one.
Yeah. Look at that, Trinity. I mean, Robbie, he's using multi-pronged.
Somebody actually asked that in one of the addiction focus groups.
What did they say?
They were saying, do 12 steps meetings work, basically.
Right.
And my answer was very simply: for some it does, for some it doesn't.
Right.
But I think that's what.
I mean, they work. It's just do they work 100%, or do they work 5%? The point is they work to some percentage, but there's other things that a person needs to do in their life to increase that percentage until you get the full 100%.
Yeah.
Right.
If you're just going to meetings, I don't think you're going to stay sober.
Not if it's just meetings.
Yeah, just meetings, nothing on the outside. I mean, there's some people that stay sober that way, but low percentage.
Right.
And I guess it bears mentioning. It's not really related to our topic, but I do believe that people who are listening to this or who are paying attention to multiple mediums, there was a school shooting, another one today, now, actually, at Indiana Middle School. It says, a middle school boy allegedly opened fire at an Indiana school Friday morning. leaving a teacher and another student injured. And I guess he's in custody at the moment.
Wow.
I mean, it's breaking like right now. So in the last like 10 to 15 minutes, this thing has been taking place. So
that's like really horrible.
I'm sure there's people right now trying to listen to us while at the same token.
What city, state? What is that?
Indiana, it says.
Man.
Noblesville. It's not very noble, is it?
No. That's horrible.
Yeah. It seems like they're happening all the time.
It's because there's pain everywhere. There's pain everywhere. And that's why when I'm saying, what's working. Yeah. I mean, you can apply that pretty much to any problem, and the school shootings being one of them. Suicides being another one. Mental health issues being another one. Well, addiction being another one. Is what we're doing working? And I'd like to say it is.
For some it is.
But there's always going to be those that it's not working for, and the news just seems to, there's so much of it now as far as like newsworthy.
Well,
maybe it didn't used to make the news. Maybe it was always there and just didn't used to make the news.
Yeah, well, I mean, my wife and I were literally just talking about this last night, actually, because there was there was another story. I can't remember what it was, but something popped up about a shooting, and my wife and I were talking about it. Right. And actually, oddly enough, this is the first conversation we've actually had about it. Right. Looking back on it, and she was just asking me what I thought the solution was. Oh, that's what it was. It was Vice News.
Oh, to the shootings part?
Yeah, it was Vice News, and they were showing the shooting that happened in Santa Fe. Mm-hmm. And they were showing some people, they're in disagreement with the Parkland kids. Because these ones in Santa Fe, they're basically saying, don't take our guns, we're a gun culture around here, things of that nature.
It's because it's Texas.
Yeah, so, and it wasn't, it was like a shotgun and something else, so it wasn't an AR-15.
No, it was a shotgun and a 38.
And pipe bombs.
And he still killed 10.
And pipe bombs.
But those didn't go off.
Which is what I was always worried about.
Right.
But
took him from his dad, though, right?
Yeah.
Yeah.
So my thing to her, when I was watching that, I was like, see, and that's an example of what I meant all along.
Right.
Was I'm not worried about the AR-15s. I'm worried about the pipe bombs is what I'm worried about. Right. But more importantly, that led my wife to ask me what I thought the solution was, because I'm not into the whole banning certain guns and whatnot. Right. And so to me, my solution was just that. Mm-hmm. Was the one thing that they all seem to have in common is pain.
Pain.
And it seems that oftentimes when you don't have the coping skills or the necessary means to deal with your pain, right, the two ways you typically kind of see it now in coping with it is I'm going to hurt others and make sure they feel the pain that I'm going through,
right, or
I'm going to self-medicate and turn to drugs and alcohol.
Correct.
And we hear an awful lot about it both right now. We hear about the school shootings, so those are ones that obviously are trying to hurt others. And then we hear about all these opiate deaths and things of that nature, and a lot of them, not all, but a lot of them are self-medicating because they couldn't get rid of that pain.
Of course.
And so I think that's what you're touching on is what works, man. How do we do this?
Well, I think that's the thing. I mean, it's if we keep focusing on individual things, like individual substances, like in the 80s we focused on cocaine, and in the 90s we focused on ecstasy, and then after that we focused on crystal meth, and then after that we focused on heroin and the opioid crisis. Addiction is a disease of pain. There's pain. There's fear. There's anxiety. There's depression. There's a lot of mental health issues going on. There's people that have been abused physically, sexually, that have gone through some serious trauma. Yeah. And you self-medicate using these drugs and stuff. So if we just focus on the substances, we never really get to the substance.
Mm-hmm. Yeah.
If we keep focused on guns, in these shootings, and everybody keeps focused on guns and what type of guns and bump stocks and all that, that's not the issue. The issue still is the pain. Yeah. From the victim side and the aggressor, the actual person who committed the violence. We're all dealing with some emotional damage that somebody's dealing with. And that's the real question. How do we deal with that? But if we spend all of our time arguing with each other over political issues, we're never really going to get to the bottom. So if you're out there and you really want to do something about all these school shootings, but you're focusing on guns and politics and saying Trump this, Trump that, or Obama this, Obama that, you're part of the problem.
Yeah.
Because you're not really focused on what the real issue is. The real issue there's young people in pain. There's adults in pain. There's people with a lot of issues going on. I don't know, Robbie, you're closer to that age group. Yep. What is it that we've done any differently for you guys in your age group that has helped you guys deal with your emotional pains while you're in school? It's different than ours because we graduated a long time ago. Maybe there's some things going on in school I don't know about.
I can't really think of anything that went on in school. I guess, yeah. There weren't any. There certainly weren't any programs where you were advised to talk to a counselor or anything like that. Mm-hmm. Or even share about what's going on. So nothing really.
See, that's what I've noticed too with my kids who are going through school now.
Right.
The thing I've noticed is that kind of that realm, if you will, is very similar to medicine. It's very reactive. In other words, once a school shooting happens, or once like my son had an incident at school a while back. Prior to that, no guidance counselors showed any interest in him whatsoever. No help, no nothing. No, hey, how are you doing?
Right.
This is how you deal with life. No nothing. Like, he didn't exist. He had an incident where had like kind of a sort of a panic attack almost, and then all of a sudden now the floodgates opened up. Then he had access to like a group and peer counseling, all those other things, but it's very reactive.
Right.
And so nobody, and so like with Parkland and some of these other things, you'll have counselors coming in and offering their services to
after the shooting.
Yeah, after it happens.
Right.
But not prior to.
Right.
And I think that is such a missed opportunity, man. It boggles my mind. I've talked about it together with you on Dharma Time.
Mm-hmm.
We've talked about it on Couch Live. I've talked about it ad nauseum with friends and family, and likewise with you. But it just seems like are we the crazy ones? Is that what it is? Like, nobody seems to get it. Nobody's talking about the pain and not dealing with it and coping. Everybody's talking about Trump or guns or pump stocks, AR. Right. Mm-hmm. But like, everybody seems to be universally ignoring this idea that the cause and effect here.
Right.
Maybe we're just the crazy ones. Maybe we're just dumb. I guess I don't know.
Yeah.
I don't think that's.
But I don't hear anybody talking about that.
Right. And there were armed guards there. There were 2 armed guards.
Where at
that school? There were 2 armed guards at that school. Still 10 died.
Yeah.
Still 10 died, even though it was a shotgun and a .38. It wasn't an AR-15. A lot more. If those bombs would have went off, it would have been a lot more.
Yeah. And don't get it twisted. There will be another one that has a better researching skills that can make a better pipe bomb.
There'll be another one and another one and another one and another one, because that same media that is using whatever format they use to memorialize and not dramatize, but memorialize those that died, rightly so.
Yeah.
Someone else, because mental health issues are real, they read that in a different way and they want to up it. Well, they want to one-up it. And it's not like we got to stop talking about it. It's not like you can stop talking about it. And it's not the fault of the media for saying this is the worst shooting of this. That's not what does it. What does it is there's mental health issues out there, period. There's really no way around it. I don't have all the answers, but I know that from a young kid, people self-medicate. And if they self-medicate with violence, or they self-medicate with rudeness, or they self-medicate by hurting themselves, drinking, using drugs, cutting themselves, or talking about suicide, or they hide within music that just is very sad and depressing, or they hide in things that are just happy and they ignore all feelings whatsoever, and they just look like everything is going great, but it's really not. I don't know. People self-medicate. That's what they do.
Well, I mean, I see it play out in my own home, to be honest with you, right?
Right.
I'll take a much simpler, much safer example. My son, my little one, he's 6 years old. He just turned 7 in May. And prior to him turning 7, when he was still like 5 and towards the end of 6, I have 4 total, but I have 3 closer in age. I have 7, soon to be 9, and soon to be 14. And the 3 of them kind of play together in what we like to call at the house the toxic triangle. Mm-hmm. Right, there's always one who feels like they're left out, and they kind of start to fight, and they argue and bicker about things. And so my little son, my youngest one, he would get upset and he would act out. Like he tried to bite sometimes, or he'd throw things, or he'd get physical. And basically, I'm frustrated. I don't know how to communicate it, and I'm going to make sure you know about it. Is basically what he's doing.
Right.
I'm going to break something. You're going to pay attention to me. Right. That's kind of how his mindset was working.
Right.
And had I let that go and not address that, it would have progressed and gotten worse.
Right.
Because he would have felt that was the way to handle things, because he's expressing it.
Exactly.
So what I did was I talked to him and said, "Hey, look, that's not how we talk. We got to use our words. We don't use our hands. We don't break things. We got to talk it out." Right. And I kept talking to him about that. Whenever things would happen, I would address all 3 of them. Right. I would tell each one of them what they did to participate in that situation. And as the time has progressed, it's gotten better.
Right.
And now at 7, he doesn't have as many of those blow-ups. But that was an example of I saw a situation where he was obviously having a hard time coping. It wasn't just a bad kid acting out. He's frustrated because he's getting ignored by 2 people who he loves and cares about.
Absolutely.
And so I saw a situation. And so it's like I see it play out in my own home. So it's not that far-fetched for me to think, had I not done that with my son at 6 and now 7, if I just let it go and just punished him or whatever and never gave him a corrective punishment, just more of a retribution kind of a thing, it was more punitive, essentially, instead of corrective. Right? So if I didn't give him the corrective stuff, what happens when he goes to middle school and somebody upsets him? He doesn't know how to deal with it. He still thinks that responding in a physical manner or breaking things or hurting things is a way to get it across.
Right.
He'll be the next school shooter.
Yeah. Or at least punch.
Yeah. And that's and so it's like I see it play out in my own home. I can't believe I'm the only one that has this in their home. I think everybody has parents or kids who are acting out in similar ways, but nobody wants to address it.
Yeah.
It drives me nuts, man. It really does. Like I feel I'm on the verge of getting on my soapbox here in a minute.
Well, the thing is there seems to be a common thread. These shooters are never guys there never seem to be the ones that can actually punch people and beat them up.
Yeah.
These are the people that actually feel kind of weak, maybe, or maybe physically they're not up to par.
More internalized anger.
Exactly. More internalized frustration. Actually, the people that probably a lot of the same people that are probably attacking them or hurting right now, defending them, giving them their little trophies and stuff, because these are the kids that probably were bullied by somebody. Yeah. You know, they look like they were bullied. They sound like they were bullied. They all seem to be kind of loners and isolated, but we all had them in our schools. We had the black trench coat kind of group in our school. They kind of just hung out on their own. Nobody really knew what they were thinking, unless you were in that group. But that group exists everywhere. It exists in Ohio. It exists in Texas. It exists in Florida. It doesn't matter.
Well, and that's the funny thing, not to, I guess, divert from that at all, but like that was one of the things I found ironic when it came to Parkland.
Yeah,
was all the kids who were up talking about bullying and everything else and getting rid of this. Yeah. How many of those same kids sat at those other kids' tables and helped them? Yeah, as opposed to bullying them.
Yeah.
When you see a kid who's ostracized and you join in that ostracization, you don't necessarily have to verbally attack them, but when you completely isolate them and you don't try to make friends, you're part of the problem.
Right.
And so all this talk about bullying. Well, really? Are you?
Oh no! In this case, so here's all these. Look, a guy. There's tons of people. There's a lot of other radio people out that have been talking about how guys are not allowed to be guys anymore. If you talk like a guy, that's like bad to even say. What do you mean, guy? It's all got to be this gender neutral. Like everything macho is bad. Yeah. Well, here's let's respect the woman. Well, this is a guy that got rejected by a woman, and this was his response. Yeah. It was rejected by women because there are women that are pretty evil to guys. They sound pretty evil to some guys too. Yeah. And she didn't do anything wrong. I'm not saying she did anything wrong. She just turned them down. Guys don't even know how to be turned down anymore. No. They don't even know how to take no, I'm not into you kind of deal. There's a lot of guys that are weird that like girls, and the girls are like, no, that dude's kind of weird. I don't like him. He's kind of awkward, and they try to stay away from these guys. Well, these guys can be pretty damn dangerous.
Well, wasn't he the? Isn't that that new subset that I wasn't? It's insub or incel. That's what it's called. Involuntarily celibate.
I have no idea
what he
was.
He was on. If we're talking about the Santa Fe one,
oh really?
He was part of the incels. They're involuntary celibate people, meaning
involuntary. My butt. Yeah, he wasn't involuntary. He got turned down.
That's what involuntary is.
I'm sorry. I was hearing voluntary. No. Yeah, involuntary.
Basically, they're dudes who.
I was hearing in my head when you were saying that he voluntarily wanted to be celibate.
No, they're basically socially awkward or whatever.
Yes.
And they can't get laid. Basically, is what it is, and they're all pissed off about it.
Why do you have to put a label on that?
Come on, dude. This is 2018, man.
Yeah, the same people that tell us to not put labels on anything put labels on everything. Exactly. That's why everything is X.
Yeah.
Well, so we wanted it. So the show today was on what's working.
Yeah.
Now we were initially wanted to just do this on addiction. What's working? And we wanted to talk to Dr. Kelly Clark from Cleanslate. Yeah. She's the chief medical officer at Cleanslate.
They just opened, didn't they?
Yeah. Or at least here in Orlando, they just opened.
Yeah.
Want to talk to her about it because she's the chief medical officer with them. But not only that, she's the president of ASAM. So we wanted to,
we got celebrity on here.
Oh yeah, she's got a great position. We wanted to talk to her about, what's working. We got everybody complaining about what's going on and how wrong everything is. We like action.
Yes.
On this show, we like to talk about things that work.
What have you done for me lately?
I'm just going to call Dr. Kelly
infamous
Clark.
words of Janet Jackson.
I'm just going to call her. Let me see if I can hear it ringing.
Let's do it.
Oh wait, I got to plug it in. Hold on. Hold on.
Oh my gosh! Come on, producer, produce.
I know. Let me produce. I'm here calling it. There you go. I'm going to try that again. I was calling it. There we go. Now I can hear it.
You're live.
I didn't have it plugged in.
Hey, it's Kelly Clark.
Hey, Dr. Clark. How you doing? It's Louis Delgado, street certified dope doctor here on the couch live, along with Trinity, Phillips, the Dharma guy, and the Grasshopper, Robbie Barrett. How are you?
I am well. How are you today?
Doing fantastic. Now, did you memorize all those names? Because there's going to be a quiz at the end.
Oh, no, and my hand couldn't go fast enough to write it all down either.
That's right. All you got to remember is Louis. You don't even need to remember the other two guys. It's just Louis.
Yeah. We're not important.
It's just all about Louis.
Okay, I can do that.
Anyway, thank you for coming on with us. So we just introduced you as the Chief Medical Officer for Cleanslate and the President of ASAM. But just so you can reiterate, however you say it, can you tell everybody who you are and what you represent, please?
Sure. Well, I'm Kelly Clark. I'm a doctor. I'm a psychiatrist and an addiction medicine specialist, which are kind of different things. I am the Chief Medical Officer of Cleanslate, which is treating, over 8,000 patients across the country right now in an outpatient setting for opioid addiction, including in the Orlando area.
Right on.
And we're using the evidence-based medications and those kinds of supports that need to be in place for people to get well and stay well in their communities. And I'm also the president of ASAM, which is every kind of medical group has its own organization. The pediatricians, the neurologists, the addiction doctors have an organization as well, and that's the American Society of Addiction Medicine, and I'm the president of that organization. So those are my, I guess that's me.
Right on. That's perfect. And so what we're talking about today on the Couch Live is, what's working, because everywhere we go, when we do a show on location, when I go do public speaking, or whenever we have different things that we do, whenever we're talking to people online or that reach out to us as either the Now Matters More Foundation or here at WPSN99.com, we hear the pains, we hear the troubles, we hear the struggles. And then today, the shooting that's even happening as we speak, that there's another shooting going on, to us, it's all kind of all within that same animal of what we're talking about, which is pain. But the question is, what's working? And if we can kind of get a grasp on what's working, maybe we can just repeat it and do more of it. But first of all, I think we have to ask, do you feel, or does it look like what we're doing right now is working?
Well, it depends on which portion of the system you're looking at.
Right.
So, we know that there has been an overprescribing of pain medications to treat pain, and we know that that's driven by a wide number of factors, including in how doctors have been taught to practice, including what is the sort of cheapest short-term treatment for pain for the payers, and including, frankly, what patients want, which is something that looks like an easy, quick, fix.
Right.
We doctors still prescribe a lot of antibiotics for viral illnesses when we know that they're not helpful, and in fact those are harmful. Yep. So there are things that we're doing to kind of pivot on that pain medication piece. I think that there's a large amount of resource right now going into talking to doctors, talking to the public, kind of getting out there the word about the dangers of opioids to treat pain. But what, frankly, there's not a lot of discussion about from the federal government and in other places is, well, okay, some people have gotten an addictive disease due to pain pill use. Many started with prescribed pain pills, and many did not. But once a person's brain has become addicted to the medication, then there are evidence-based treatments that we know work.
Right.
And that's what we need to be talking about. And we also need to tell people the difference between just being dependent on a medication and being addicted to a medication.
Okay. So let's start with the first part that you brought up. The first part being the physician itself, because we are seeing that over 80% of people, the latest numbers have been 80% of people previously misused pain prescription medication before using heroin. So if we're just looking at the heroin users, and there's a lot of them, we're seeing that that's the route they came in. So the days of talking as marijuana as the gateway drug for a lot of people that were out there with that banner, that's kind of gone right now. Right now, what we're able to say is we do know pain medication or pain pills have led people astray a little bit right now. Now, when you talk about the physicians, what are we doing differently as far as training physicians? Because I have seen nothing to say that the medical schools have now added additional training to the physicians. Has something changed, or is somebody pushing a change within medical schools?
Yes, but let's go back to, let me just say something about the marijuana as a gateway drug, and it's unquestionable marijuana is a gateway drug. Alcohol is a gateway drug. Pretty much whatever drugs of abuse are most available are gateway drugs, particularly in youth.
Yeah, that could be anything.
Have fully established brains. That's correct. So I would not minimize the harm of marijuana. In fact, people who, and particularly youth who are using marijuana, are at higher risk for developing an opioid use disorder. So.
Well, don't get me wrong. I'm not minimizing. I just know that there's people out there utilizing this problem as a banner for that, and it's not the time to have that argument, is what I'm saying. This is not the time that we talk about that, because if that were the case, we need to get real honest about how we give our kids sugar and caffeine and how we start the brain going in this direction in the first place. But what I'm saying is, since we know prescription pain pills have been an issue, and we saw pharmacies get attacked, we saw pill mills get attacked, but we didn't hear anybody addressing the medical schools.
So I would say that since the CDC came out with their guidelines for use of pain medications, and frankly, since the use of the prescription drug monitoring programs, where doctors can actually see what the patients are getting from other prescribers, with the changes in a variety of state laws requiring continuing medical education on pain or addiction in order for doctors to continue to have a license in the state, there's been an increasing push on educating doctors around the utilization of pain pills to treat particularly chronic pain. But a lot of the people who started on pain medications weren't prescribed them themselves. They got them from
Correct.
friends or relatives
Correct.
who were prescribed them.
Correct, but that means that a lot of people were, but we do see a large amount of prescriptions for people per capita that was a lot higher than the norm. So they were still able to find physicians that were freely prescribing these pain medications, and we have a pretty good way of monitoring a lot of that just wasn't happening.
Right. And then we get into the issue that, look, if we even stopped prescribing all pain medications right now, the highest rates of death haven't been with pain pills. Now they are with the illicit opioids, heroin, fentanyl, carfentanyl, because this is something that they taught in Economics 101, which is that if you've got a decrease in your supply and you don't have a decrease in the demand, one of the things you're going to see are substitutes. So
of course,
as there are less pain pills out there, but we still have over 2.5 million Americans whose brains have become addicted to opioids. Until we provide them with actual evidence effective treatment rather than what just people might just call treatment, that demand will still be out there, and we will continue to see those substitutes.
Of course, but we do have to empty out that pipeline, and I think that's why I was asking about the medical schools, because we have to make sure that the pipeline doesn't get full again, because we feel like, I think the law enforcement officers, I think, did a real good job as far as finally closing down the pill mills and stopping a lot of that, and a lot of the regulations have kind of killed the pipeline for the pills part, not the heroin part, for the pills part, which was feeding the heroin market, which was feeding the fentanyl market. But again, I mean, I don't think anyone, and that's why I was asking you, because as a president of ASAM, I was kind of hoping to hear that maybe all medical schools are forced for physicians to take a class on addictions, because as far as I know, you can get all the way through medical school without taking a class on addiction or dependence, but instead it's part of courses. Is that true?
Yeah, the typical trainee is going to be less than 8 hours during the course of the 4-year medical school curriculum.
And that's kind of unfortunate, don't you think?
Yeah, what we see right now is, and this is a great sign, the actual medical students are demanding more traiing. They are demanding training, yeah.
Right on.
And so there are actually bills in front of Congress right now that came directly out of medical students to provide some grant funding for medical schools who elected to build some curricula around treating pain and addiction.
Great.
And
So
I think that's a great sign that the youth really understand that they need to be teaching and learning about evidence-based approaches.
Isn't that always the case? The youth comes out and they crave knowledge. So it's just as long as we step out of the way and keep these young physicians that are coming in that really want to do a great help. They want to really help people. We want to keep them focused on helping people rather than coming out and then getting frustrated with the insurance system, frustrated with the payer system, and then end up getting wooed by some new venture of how to make money quick just by signing a bunch of prescriptions, right? Hello?
Yeah. Well, Jed, I can't say anything.
Well, because I'm just saying,
that the medical students are stepping up here
I like
and understand the issues.
I like that because now that medical marijuana is being prescribed, starting to get accepted. What I fear is, you have a bunch of new physicians come out, and instead of getting any training on addiction or anything, they just start prescribing that now, and that's just the next problem that we'll be dealing with. Not that any specific drug is a problem, but it's us that are the gatekeepers being able to just open those floodgates and not educate our clients properly or not educate the patients properly. I think that's the problem. So it's good to hear that young physicians are coming out wanting to have that knowledge and that schools are willing to do something about it. So that's what ASAM, or that's what the medical schools are doing. So now to the problem. You said that the brain is changed. Can you educate the people a little bit about how the brain has been changed and explain a little difference between addiction and dependence? Because I think people really do need to know the difference.
Sure. So dependence is basically when somebody or even an animal receives a substance, so say a drug, for long enough that their body kind of gets used to it. And their body gets used to it so that they need higher doses of that drug to receive the same effect. Or if they stop taking it, they have a withdrawal symptom from it. And so the way I would say, and that's not dependence. I mean, that is dependence, sorry. That's not addiction.
Right.
Okay? Addiction is, so for example, when babies are born to mothers who've been taking opioids, the babies are not born addicted.
Correct.
The babies are born dependent.
Correct.
They're physically dependent. Addiction is a chronic brain disease where we know it impacts specific parts of the brain, and those parts of the brain are responsible for things like impulse control and decision making and problem solving and learning, and exactly those things that we see impaired by people who've got addiction. Right. And you can see some of these changes in the brain with scanners or on autopsy. But in practice, since we don't all walk around with scanners and we certainly don't, do autopsies on our patients,
right?
The way that we see that is people lose control of their drug use, and then they lose control of their lives because they've lost control of their drug use, and that's really addiction. So my example of dependence for you would be, imagine a woman in her 70s who, for some unknown reason, in her mid 30s, decided it would be good to take off-road motorcycling as a hobby. So no idea why. But in her 70s, by this time, her knees and her hips are pretty much shot. And so her doctor prescribes her a teeny dose, a small dose of an opioid to take 3 times a day. And she sets her watch and she takes it.
Right.
And then after a while, it doesn't work. And so her doctor says, okay, we'll take the entire pill 3 times a day. And she sets her watch and she takes it. And then over time, things get worse and she becomes bionic, getting new knees and new hips.
Right.
And so then suppose her daughter calls her up and says, hey, Mom, how you doing? Well, I'm doing great, except I think I have the flu. Imagine her daughter's a doctor and says, Mom, why do you think you have the flu? Yeah. Well, I'm sick to my stomach. I feel like I could throw up. I've got diarrhea. I've got chills. I'm sweating. I can't sleep. Well, Mom, have you changed any of your medicines? No, I haven't changed anything. But I did stop that pain medicine. I don't need it anymore. Now, that is dependence.
Right.
Taking exactly as prescribed, but not addiction.
Right.
And happily, my mother's left Florida for the summer, so she doesn't know I'm talking about her on live radio.
Yeah, and we see it all the time, don't we?
Yeah, and if what addiction looks like is losing control of drug use and then losing control of lives. And so some people get confused and they think when people get on buprenorphine or methadone, then buprenorphine's names are Suboxone or Zubsolv or Bunavail. But when they get on those medications, sometimes people think, well, they're just substituting one drug for another.
Right.
But one of the ways that we know that that's not true is that once people get on those medications, they actually get control of their drug use and they get control of their lives back. People they don't seem to have that understanding about the injectable naltrexone product. Which is Vivitrol, but they have that misconception about the others. And it's just really important for people to understand that chronic brain diseases like addiction require a biological and social and psychological approach.
Yeah, I think they need to understand
all of that.
I think in educating people the difference between a partial agonist and an agonist kind of helps that, without having to use that word obviously, but they need to understand that there's a blockade attached to it as well that can kind of help them control it, just like you said. But you're right. There's a lot of people with a lot of opinions on their own. They want everyone to get sober the way they got sober. They want everybody to get clean the way they envision being clean, rather than, listen, harm reduction models may work for some people. Medication-assisted treatment may work for some people. Other different models of getting clean and sober fully may work for some people. But as long as they're moving away from the thing that's actually killing them and further hurting them, we should support that and kind of get around them and rally around them rather than knocking them down for it.
Yeah, so as a doctor, and I'm a psychiatrist as well as an addiction doctor, so if a person comes into me and they have, say, a major depression, and I don't offer them Prozac or some kind of medication, then that would be inappropriate practice, because the evidence base shows that people can get better faster and functioning better, and medication is a standard of care. So I need to offer them medication if they come into me with major depression.
Right.
And if I were, say, a psychotherapist and could not be prescribing myself, then I would need to offer to refer them to somebody for medication.
Correct.
Now, at the same time, I would also say, look, there are some certain kinds of talking therapy that I know can be very beneficial to you, and so I would like to offer you those or refer you for those as well.
Right.
But what I couldn't do as a doctor is say, you've got major depression, I'd like you to take, just these vitamins and come back and see me.
Right.
And I hope that your suicidality doesn't get worse. That would be inappropriate. So this is the same thing for opiate addiction. What we know is people who get on and stay on medications to help them treat their opioid addiction actually have better outcomes.
Right.
And that people who go inpatient for a detox and rehab, if they leave and they're not on medicine, they actually have a higher risk of dying than if they hadn't completed the program.
Well, I mean, let's talk about the stay on, because I think it's the stay on that people become afraid of. I think I think there's an issue with I think there's some same doctors or some same kind of investors who invested in pill mills, who also invested in certain clinics that will only take cash. And I've talked to you off the air about this, and so I can't wait till you come into town, because I'd like to hear more about maybe what's happening in other areas. But I know in our area, at least, we have very good, and I'm going to use the little quotation marks, good physicians that are only accepting cash and only on certain days doing some of the same medications that Cleanslate may do properly. But we have to police our own people, because our own treatment industry is not only misusing it, but just handing that out. It appears that they're handing that out pretty freely as well, but for dollars, not necessarily for the care of the patient. In other words, the patient doesn't have to be in counseling. The client doesn't have to be doing anything else other than just coming back once a month for an appointment. So which hurts, which hurts what you're trying to do, or what ASAM is trying to do, or what any good program like Cleanslate is trying to do. It hurts you because it puts you in the same boat to them.
Yeah, it is true. And so providing quality care is an absolute baseline. And people should know and demand care that's effective and works. They should just demand that. So, at Cleanslate, which is there in the Orlando area.
Correct.
People come in and they get a physical, they get evaluation, they get the blood work done, they get, all of the clinicians there are actually trained in the psychosocial interventions that are evidence-based. They have fancy names, but the clinicians are all sort of trained in those.
Right.
Not everybody who takes Prozac needs to be in psychotherapy.
Right.
I mean, there wouldn't be enough psychotherapists in the country, to deal with that. So people need individualized care, but based on best practices, based on structured best practices. And the truth is that a lot of providers aren't structured in a way that they can get contracts with health plans to take care of those covered members the way Cleanslate can. They're not. They don't have the infrastructure or the training and how to interpret those drug tests, or people who can, provide the kinds of things, the additional things, the wraparound care coordination pieces, which are so essential for people who are in treatment. And to be clear, using medications to treat opioid addiction we don't call that harm reduction. We call that treatment the same way we call Prozac treatment of depression. But, I can't just prescribe you insulin for diabetes and think that's enough.
Right.
That's not how it works. Managing a disease state where you have to deal with it, as they say in AA, one day at a time. It's, a minute at a time. And it involves having the psychological strength to help manage your disease and the information to do that. It involves engaging the family as needed and having the right support structures in place. It's not as easy as prescribing a pill, and it's frankly nowhere near as easy as thinking you can go away for a month and come back cured, because we know that doesn't work for any chronic disease state.
Correct. And we all know that active addicts look for an easier, softer way. It's been the way ever since I know it to be. I got 29 years clean myself and been around the rooms for 29 years, and everybody always wants an easier, softer way. So if you offer them a way without having to do harder work or any psychological work or counseling work or group work or 12 steps or any kind of thing, and you're just going to give me a medication and I'm going to feel like, well, that's all I need then. Well, of course I'm going to try to do that, but I just think it's a little bit irresponsible to just give anyone simply a medication for this problem, for an addiction problem, without offering them and kind of almost demanding a little bit more from them, or else maybe you're just not the doctor for them. And I really give it up. I give props to the physicians that if you're not doing that other comprehensive management stuff, if you're not going to counseling or 12 steps and other stuff like that, then I'm not the doctor for you. I give them props for that.
Yeah, and well, the bottom line though is, we can't, I wouldn't say to a patient, I'm only giving you Prozac if you go see a psychotherapist as a general rule. Right, because that wouldn't be an appropriate individualized care. And I can't say I can only treat you if you will accept platinum level care. That's not appropriate. However, the individualized care is something like, if that person is, if I'm giving that person medication and talking therapy and they've got, say, a heart condition that makes the medication dangerous, I won't continue to see them if they're not going to their cardiologist. Or if they're not doing well, and I think that they're at risk, or suddenly there's something that's a problem, they need to embrace higher levels of care at some point in order for me to treat them. But I wouldn't say a person is
well, I'm not going to
condemn them.
Well, I'm not condemning. I just wouldn't compare the two, because I don't find there to be a in dealing with this, and I don't mean to disagree with you, but we don't have the same kind of med-seeking people and destructive people that are seeking the Prozac as they're seeking other forms of medications that our industry is providing. I think we have the clients that are kind of doing both. But our clients can be not only just suicidal, but homicidal. Our clients are really destroying themselves in a very serious way. And so I think it's the psychiatrists that just offer Prozac do not appear to be the same kind of physicians that are just offering the other, whether they're a Suboxone doctor. I mean, there's some people with that's their name on their email, Suboxone doctor. Okay, so they're not saying I'm an addictions doctor or a recovery doctor. I'm a Suboxone doctor. All right, and so if you come to me with a heart condition, I'll take your insurance. But if you come to me with Suboxone, you have to pay me $250 cash. So again, we didn't see that with depression. That didn't happen with. There's no Prozac doctor out there. You know what I mean?
It's true. You're exactly right. That would be something more.
So that's why I'm a little bit more. I'm not going to treat them both the same, because we have a different level of physician that is jumping into our market. Again, it's the same physicians that jumped into a good industry of pain management. That's a good industry. We need pain clinics, and we had illegitimate. I don't know what to call them, illegitimate or just crooks that just happened to get medical degrees that came into the pain management business and destroyed that business. So now if you call yourself a pain clinic, you just sound bad here in Florida. You know what I mean? You can't even call yourself a pain clinic anymore without someone giving you a side eye. And that's that's a necessary business. There's people that it's saved their productivity levels. It's saved their lives to be able to go to a pain clinic. So in our addiction treatment, we've had the same kind of doctors now flip into our business and now jumping into either only prescribing Suboxone or only prescribing marijuana now. And so you have the same doctors that they don't really care about the recovery of a client. They simply want to give them what they know, they want without having to do anything else for it. And that's why I'm saying we need to be a little bit more strong and a little bit more serious about it. It's almost like these treatment places that advertise these spa-like conditions for treatment, but never even mention a 12-step program. Right? Because 12-step programs advertised make people stay away from there. Because when they call up, they go, can I smoke there? Do I have to go to meetings? You know, those are the questions we all get as I've owned treatment centers for 28 years. So if I say you can smoke at my treatment center, boom, I let you. If I say I can give you I can give you the cell phone, boom, now more people are coming. If I say that you don't have to go to meetings, more people are coming. So we're doing things out of commercialism rather than what's really best practice for the client. I don't think that's individualized treatment. I think that's, let me give you the treatment that you want, therefore you become my client.
Right. Totally inappropriate. I couldn't agree with you more.
Right.
And I would, just for your listeners to help educate
Sure.
themselves, when they and their family members or their neighbors or something are looking for, well, what should I be expecting out of any kind of doctor's office or program? Now, methadone cannot be done out of a doctor's office. Naltrexone and buprenorphine can. But any program that's utilizing, or physician that's utilizing these medications,
Right.
ASAM has a booklet for families and friends and patients that would be at asam.org that is based on the
Right.
best practice guidelines. So folks can take a look and see this is what those elements of that treatment should be. And they should demand that treatment. You know, one of the issues and one of the reasons that there are cash doctors out there in the space is, frankly, that the insurance companies aren't paying for the care.
Right.
They're not contracting with an adequate network. They don't want to actually seem to pay for the services, or enough for the services to make it worthwhile of the doctors to do it, so the doctors aren't losing money just doing the services. They won't accept anyone except for a psychiatrist to do the services when we need all hands on deck prescribing here. You know, there are barriers that are being put up by health plans.
Yeah.
Folks that are covered, if you can't get in to see the kind of quality care that you can read about in that ASAM place, if you can't get into a place like a Cleanslate, then call up that health plan that's covering you, because they're supposed to make sure that you can access appropriate care.
Right. Yeah, and like you said, I mean, having a limit, like I don't think there was a limit on how many pain pills a person can prescribe, but there were limits on, I mean, there's still limits on Suboxone, right?
Doctors can only have 30 patients for a whole year that they start.
When they first start, right?
Yeah, when they first start, and then only 100 patients at a time for an entire year. I mean, we can write all the pain pills we want. We can
Right.
write all of the Xanax and Valium we want. We can write all of the Ritalin we want, but we can't actually write this.
So who regulates that? Who made that the rule?
That's the federal government.
So how do we change that rule?
There's actually a bill right now in front of Congress that didn't get a hearing in the House last week, but hopefully it will come back again. It's the Tonko bill that would allow for doctors and nurse practitioners, physician assistants,
Right on.
to go right to 100 in the first year, and then to 275, which is the upper limit by law right now, if they are working, either they're board certified addiction specialists, you know, like myself, or
Right.
they're working in a qualified practice setting like a Cleanslate.
Beautiful. I love it. See, so there are solutions. So if what you're hearing Dr. Clark say, again, we're talking to Dr. Kelly Clark from Cleanslate. She's the Chief Medical Officer of Cleanslate, and Cleanslate all over the country. You can go to is it cleanslate.com, or what is the website?
Yeah, it's cleanslatecenters.com.
Oh, I'm sorry. Cleanslatecenters.com, and you can see if there's one in your state. I know they're in Texas. I know they're here in Florida. Any other states that I know there's a lot of other states, but
Oh yeah, Texas, Connecticut, Arizona, Massachusetts, Pennsylvania,
Wow.
Indiana. I know I'm going to miss some here.
yeah, that's what I was feeling.
DC.
You know, it's a great thing when you're the chief medical officer of a place and you can't remember all the states. There's so many. That's awesome.
You know, we're growing really quickly, which
Really
is both unfortunate that there is a need,
Right.
but awesome because we can help fill that need, and
Right.
that's really mission of the company, is to expand access.
Right. Well, we have
to,
Dr.
you know, to
Barbosa.
NHS care.
Dr. Barbosa down here that came from the Pennsylvania area. She's now here for you guys, Cleanslate, and she's an awesome person. It's beautiful meeting her. And you're going to be coming to a conference. We're actually having an Orange County conference here in Orange County. So if you're here locally, Dr. Kelly Clark's going to be speaking at that conference. Trinity, do you have that information so you could tell everybody about that conference? Do you have it
I don't.
readily available?
It's on my phone,
It's on your phone?
which is being used for live right now.
Well, that's not very good. And my phone
It is actually.
You have it on you, don't you, Dr. Clark?
It's actually next Thursday.
Right on.
There in Orlando. It is it's at the Valencia College School of Public Safety in the first floor auditorium.
Right on.
Is where it's going to be, and it's the annual conference.
Mm-hmm.
There for your the focus group there. And it's called Enough is Enough, making a shift from apathy to action.
Absolutely, because we're done with this apathy stuff. As you can tell, I mean, we get fired up about it here, Dr. Clark. I could talk about this stuff all day because it really bothers me.
I can tell.
The inactivity, the level of inactivity, and the people just, they act like they care, but they really don't. We care more about puppies, which is fine. I love puppies too. But, if I had this many people dying around, this many puppies dying around me, then I would care a lot more about puppies. I got way too many people dying around me.
Puppies, kids, and cancer.
That's right. Puppies, kids, and cancer.
I just hear people and they say things. They say, they just don't care about, quote, those addicts.
Yeah.
And I ask, do they care about, quote, those orphans?
Right.
Because that's what we're getting right now.
Right.
We're getting just a whole generation of kids whose parents are absent, and the truth is that we can't change the 50% of addictive disease predisposition that's genetic.
Correct.
But the 50% that's due to absent parents, neglectful parents, chaotic family environments, etc. That's a parent who's in throes of active addiction. Treating addiction is prevention for youth.
Right.
If we do it in a evidence-based way.
Right.
The thing that fires me up is these programs that say that they've got, an 80% cure rate
God.
Because, 100 people come into some program, 50% graduate. Like, how do you graduate from treating diabetes? Okay, 50% get done. And then 6 months later, they reach 10 people by phone out of that original 100. And 8 of them say, oh, yeah, I'm doing great. And then the program says they've got an 80% cure rate. It's just, that makes my blood boil.
It's ridiculous.
We were just talking about that.
That just makes me, that is so horrifying. People
criminal.
need to get informed consent. They need to know what they're getting and what their options are.
Yeah. I mean, it's bad enough that we have to, your doctor can write one prescription, but because you have a certain insurance, you have to take a completely different pill or a different kind of medication, or that medication is not even offered. It's amazing who controls everything.
Yeah.
Well, that's actually the way that they keep the prices low.
Mm-hmm. Well,
otherwise, the drug company could just charge anything they wanted if the payer had to pay for whatever was exactly prescribed.
Well, I think there's other ways to do it rather than having that kind of lobbying power to be able to make people all take.
I think we're going to have a really long conversation there.
Yeah, exactly. I really love it. I love that ASAM exists. I love that a grouping of physicians can get together. And I know I've been to ASAM conferences, so I know the trainings are pretty intense. But those physicians actually want to know more about this. I'm more concerned about the average physician that I talk to on a regular basis, and I mean on a regular basis, that tells me this sentence right here. I don't see addicts in my practice. I don't have addicts in my practice. I refer them out. And I'm thinking every doctor has addicts in their practice. You just don't know because you don't ask.
Well, asking is going to be less impactful than checking a prescription drug monitoring program and doing a drug test.
Absolutely. That's for sure.
You don't know what a person's actually taking unless you've got some blood or urine, some kind of a fluid
100%.
to look. Because
100%.
they could be prescribed, but it's not being taken. Or it could be being taken and it was never prescribed.
100%. Because when I was a youth and I was using pretty heavily, that doctor absolutely tested me for drugs, knew exactly that I was taking drugs. But because of, for whatever reason, whether it be my father's rank or whatever, never said anything to my parents. And the proof was right there the whole time. When I was having all kinds of little medical issues that they were trying to figure out what it was, the answers were there the whole time. But if you don't test for it, you're not going to know. You're not going to know. And it's unfortunate. But anyway, thank you
part
very
of the
much,
reasons they don't test is because they don't know what to do with the results.
that is the reason, right? I would say that is probably the number one reason, is because then what? What are you going to do with the information? Oh, one last question I have to ask you before letting you go. All right, so if we did have our version of the X-ray, which is mandatory, like a PET scan or something, which scan would be the best for us to ask for or want as a grouping? Because I think it would be nice to have an X-ray. Because when a doctor says, I'm going to cut your brain open because you have brain cancer, they show them something and says, here it is. So it makes it pretty easy for you to say, yeah, you better cut my brain open like today.
Yeah. You don't want to be doing those scans because they involve like injecting radioactive stuff into your body.
Yeah, so what's the best scan though? What would be our version, like so far to date, what would be our best version of a scan or test or MRI or whatever that would actually show that addiction or dependence has crept into our brain, that we're able to see some differences and changes within that frontal lobe area or even deeper?
Yeah, it's deeper. Actually, the best tests are done on autopsy, which you really don't want to do.
Ouch. Never mind.
And the thing that's so I was going to say cool as a scientist, as a physician, is that if you take the brains of people who are alcohol addicted, and you look at them on autopsy, they have a lot of diffuse changes in the DNA throughout the brain. But if you take the brains of people who were heroin addicted on autopsy, they have specific DNA changes in specific regions of the brain. They look totally different than alcoholic brains.
Interesting.
Which is one of the reasons, I think, why perhaps what worked for alcohol, that detox and rehab model, doesn't work for opioids.
Interesting. That's a very good point. Even though it uses a lot of the same receptors, because alcohol likes to throw your endogenous opioids, all into the receptors. But there's specific changes with specific drugs. Yeah, a drug is not true. Now addiction and dependence, there's a lot of similarities in how to be treated, but a drug is not true. And we need to do a lot more education. I appreciate people like you, Dr. Kelly Clark, that's out there speaking on this, and I can't wait to see you in Orlando and meet you person to person this Thursday. So that'd be next Thursday. So a week from now, just about. So anything else that we need to know of Cleanslate? You're opening up here in Orlando. I can't wait to go. I haven't done my tour, and I was supposed to speak at the grand opening, but it got pushed off because you guys were opening something else around the same time period.
Things are moving pretty fast there. Right there in Orlando, people can call 407-571-0285 if they're in the Orlando area.
Right on.
Or just look on the website and it'll direct you there.
Right on. CleanSlateCenters.com. Anyway,
exactly.
We've been speaking with Dr. Kelly Clark, Chief Medical Officer with Cleanslate, and also President of ASAM. Thank you very much, Dr. Clark. We appreciate you being with us today.
Thank you, Louis. Keep up the good work.
Thank you. Bye-bye. All right, and that was Dr. Kelly Clark.
Right on.
We got 1 minute left to go. You guys stayed silent. I'm sorry, man. I do that.
No, man. It was informative. I think she needed her time to talk.
She did need her time.
Yeah. It's a big name person on the show.
It's a big name person. It's a big problem. Every time I talk to her, I think it looks like I argue with her a little bit, but it's not on purpose. It's just
I think you always look like that, though.
Yeah, it's just the way I talk, right?
Yeah.
But, it's just, there's certain things I just feel real passionate about. I personally, I just think everyone should be in counseling, at least at the beginning of your addiction treatment. I'm just not into any, give a medication and don't do. But I believe that with antidepressants, too, I think you should initially do treatment or some form of counseling. Anyway, Trinity. Anything else that we need to talk about before we go?
I think that's it. Have a good Memorial Day weekend.
Memorial Day weekend. Thanks to people like my father and my brother who are veterans. They didn't die, thankfully, so we're not memorializing them. But both of them are veterans, and thanks to my brother Jimmy and my father Jim for serving, and to every other person out there who's ever served in any of the armed forces. Thank you very much for putting in work. Robbie, anything?
See you later, guys.
That's it? That's all you got to say?
That's it.
You have nothing else to say?
Thanks, Dr. Clark, for a really informative show.
Right. All right. So from all of us here, adios, amigos. It's time for a taco. Goodbye.
And that was without even a single drop of rum.
Thank you. I'll be here all week.
He really grows on you, doesn't he?